Hi, my name is Caitlin Edwards, and this is my case study for DMS 4420. The case study that I chose for this assignment is for May-Thurner syndrome. Just a quick introduction of the patient. There is a 28-year-old female who arrived at the ER with complaints of having left upper thigh pain and leg edema from her hip down to her ankle on that left side. She said that she had been having these symptoms for about 3 years, but within the last couple of days they began to be more persistent. The physician first ordered bilateral lower extremity venous Doppler ultrasounds, and then to follow that exam, a CT angiography of the abdominal pelvic region. The physician wanted to rule out any chronic deep vein thrombosis, a venous compression by mass, May-Thurner syndrome, or any scarring of stenosis of vessels in that area of concern. So the first exam, the bilateral venous Doppler ultrasounds, came back with normal findings. There wasn't any DVTs or anything found in that exam. The next exam that was performed was that CTA of the abdominal pelvic region. There was seen to be normal arterial anatomy, but they did find that the left iliac vein was being compressed by the right iliac artery. So as looking in this picture here, this transverse CT scan, we can see starting from left to right, there's the right common iliac vein, the right common iliac artery, the compressed left common iliac vein that is harder to see, and the left common iliac artery. The patient was diagnosed with May-Thurner syndrome. What is May-Thurner syndrome? It is a compression of the left common iliac vein by the right common iliac artery. The compression of the left common iliac vein by the right common iliac artery. As we can see in this diagram here, you can see the right common iliac artery crossing over the top of the left common iliac vein, causing a compression. It's compressed between the common iliac artery as well as the vertebral body around the level of L5. After the compression, you can see a ballooning area within the iliac vein. So this happens because there's a chronic pulsatile motion of the iliac artery that irritates the endothelium of the iliac vein. This is a progressive disease that can lead to many complications and disabilities of the patient. This is most prevalent around women ages 20 to 40. It was first discovered while dissecting cadaver bodies. I believe from my research it was found first in the 1850s. But wasn't given a name or anything until 1950s when May and Thurner both discovered this pathology while dissecting cadaver bodies. There is a few symptoms that can be persistent with this pathology. Persistent left leg edema, varicosities, and DVTs. Because May-Thurner syndrome can cause DVTs after the compression area, the DVTs can lead to pulmonary embolisms if any of those pieces break loose. There's a few different names for May-Thurner syndrome. There's iliac compression syndrome, iliac vein compression syndrome, Cockett syndrome, or Ilio-Cavell syndrome, compression syndrome. So the protocols for this exam is usually what the ER physician ordered for a case study patient. They first order that Doppler ultrasound. They use it to rule out any type of stenosis or DVT within the vessels of that area of concern. The common iliac vein can be hard to visualize with ultrasound depending on the patient habitus, but a lot of physicians can agree that it's worth trying to start with the ultrasound first before moving on to any exam that can use radiation or expose the patient to any radiation. If the ultrasound is unable to identify any stenosis or does not adequately visualize the left common iliac vein, they usually jump to a venogram or angiography CT. This exam pushes contrast through the vein to identify any blockages or narrowing of the vessel. It does expose the patient to ionizing radiation, but you can visualize far more pathology than seen on any ultrasound. The course of treatment for May-Thurner syndrome, there's a couple different options. The more invasive options are a vein patch angioplasty with removal of intraluminar bands. Another option is relocating that right common iliac artery behind the left common iliac vein or vena cava, so that way it's not compressing it, it's running under the vein instead. Or a temporary arteriovenous fistula created from grafting the saphenous vein from the contralateral side to the ipsilateral side of the common femoral vein. A less invasive approach is the endovascular stent placement. This only provides short-term results, but on the plus side, it is less invasive and a lower risk than having any of those other serious treatments. Also, more conservative treatments, including wearing compression stockings and taking anticoagulant medications. However, those aren't long-term fixes for this pathology. The goal of treatment is to reduce any chances of further complications from happening. So in this picture, you can see the compression of that left common iliac vein without the stent, and then the picture to the right is with the stent. You can see how it's more open and allows for better blood flow in that vessel. So our patient follow-up, the 28-year-old did decide to have the stent placed in that left common iliac vein. It also extended into the external iliac vein. You can see it here in this picture, that more brighter area running down the vessel. The physician didn't prescribe any anticoagulants to our 28-year-old patient because there wasn't a DVT found in her ultrasound exam, so there wasn't any concern for pulmonary embolism or clots within her veins. And this is my works cited.